Welcome to the Pupil Pod, where we use clinical cases to guide discussions on board review topics. I'm your host, Ogul Uner, and my guest today is Dr. Kingsley Okafor. Dr. Okafor is a board-certified cataract, refractive, and glaucoma surgeon at Colorado Ophthalmological Associates in Denver, Colorado, and I'm so excited to have him on the podcast today. Dr. Okafor, thank you again for joining me.
Oh, very happy to be here. Happy to share the knowledge on this interesting case.
Thank you. So with that, let's dive straight into our case. We have a 40-year-old man with no past ocular or family history who presents to your clinic with left intermittent visual changes and eye pain. He reports halos and eye pain that seem to occur during his daily runs. On examination, he has a moderately myopic prescription. His best corrected visual acuity is 20/20 in both eyes, and his IOP is 19 in both eyes. You notice pigment on the corneal endothelium and midperipheral iris transillumination defects in both eyes. Gonioscopy in both eyes show open angles with 4 plus pigment and speckled pigment anterior to Schwalbe's line. The cup to disc ratio is 0.4 in the right and 0.65 in the left, with a superior notch on the left optic disc, and there are no disc hemorrhages in either eye. You obtain an optical coherence tomography of the retinal nerve fiber layer, which shows intact rims on the right and superior thinning on the left nerve. Dr. Okafor, what are your initial thoughts about this case?
I'm a little concerned about this patient. Number one, they're young, and two, they're having some borderline IOPs. We're seeing pigment on the cornea, corneal endothelium, concerning for pigment dispersion. And given the asymmetry in the optic disc appearance, I'm concerned for potential glaucoma, definitely on the left side, and I think the right eye is probably suspicious. So definitely considering pigment dispersion and or pigmentary glaucoma.
Great. And you hit right to it. I always think of pigment dispersion syndrome and pigmentary glaucoma, as you discussed, in kind of in a spectrum. So I think for our listeners, when you do have evidence of optic nerve damage, we just call that glaucoma. So with that in mind, could you describe the findings of pigment dispersion syndrome?
A very important finding in pigment dispersion syndrome would be a Krukenberg spindle, which would be the pigment on the on the endothelium in the anterior chamber. I also think about transillumination defects in the midperiphery as well as findings of pigment dispersion.
Yes, I think about it like you said about the iris essentially releasing a lot of pigment into different areas of the anterior chamber. Whether that's on the corneal endothelium, whether that's on the lens capsule, or whether it's also on gonioscopy when we talked about that pigment anterior to Schwalbe's line, thinking about a Sampolisi line is also one of the findings, like we talked about. Well, do any of these findings are they pathognomonic for the condition? Can they be seen in other diseases?
I think you should always consider pigmentary issues if there's pigment in the eye, but other conditions can also mimic this. Notably, pseudoexfoliation can also lead to some pigmentation. Also, tumors and/or trauma can also lead to increased pigmentation in the eye.
Those are great points. And pseudoexfoliation and pigment dispersion do carry a lot of similarities. And for those who are listening, I tend to think of them more in different age ranges. As we talked about, in younger patients, we get more pigment dispersion, in older patients with pseudoexfoliation. But both of them can produce the pigment anterior to Schwalbe's line, which is the Sampolisi's line, and then the increased pigment like our patient. So, what exactly is the pathophysiology of pigment dispersion syndrome? Why do these patients get it? And why is it that so important in terms of it producing glaucoma?
So classically, in these patients that are myopic, I like to think of these large myopic eyes with large irises, and you'll have a posterior bowing of that iris tissue that's rubbing on the lens zonules. That rubbing will liberate pigment, and the pigmented cells in the trabecular meshwork just kind of get clogged, and they don't work as well as they would without those extreme amounts of pigment.
I think the myopic prescription is so important, as you said, to the pathophysiology, and it Makes sense. So, with that in mind, could you discuss the risk factors for pigment dispersion syndrome and the prevalence of glaucoma in this population?
Of course, think the kind of the buzzword we always think about is the young myopic male. So males are more common, up to three times more common. Middle age, which kind of hurts me to say that 40 is middle age or considered middle age, but somebody middle age should be considered. Again, that younger patient, myopia, and then about 15% or more, depending on your literature source, could progress to glaucoma. Interestingly, pigment dispersion does not necessarily mean you will get pigmentary glaucoma, but something to think about.
With all of that pigment being liberated, what are some treatment options for these patients and for those who have pigmentary glaucoma? You talked about the reverse pupillary block configuration as the potential pathophysiology. Would there be a role of laser peripheral iridotomy in this case?
So to start with treatment options, I think of all reasonable treatment options for glaucoma should be considered. As a glaucoma specialist, I like to start with conservative options, drops. I think lasers can be considered as far as SLT, but I think there's a tendency to consider laser peripheral iridotomy given the mechanism or pathophysiology of the pigment dispersion. However, large studies, including Cochrane reviews, and if you're not familiar, Cochrane reviews are large studies that look at meta-analyses to understand if there's clinical evidence for certain questions, did not show that laser peripheral iridotomies were helpful in these patients.
That makes a lot of sense. So uh, LPIs are not very helpful, and that treating the glaucoma as is, with drops and filtration surgery and our other glaucoma treatments effective. So going back to our case, this patient would like to avoid drops as much as possible. What else would you recommend as treatment?
I think selective laser trabeculoplasty is an excellent treatment option for these patients. I think everyone should consider it with caution. I've only had one intraocular pressure spike with SLT. It was quite substantial, and that patient did have pigmentary glaucoma. They did resolve, but it definitely reminds us to be very cautious and go low and slow with the energy in these patients.
And so, speaking of the energy, could you provide us with some pearls on SLT in these patients? Like, what energy do you start with? How do you approach it? Do you do 180 or 360? And what is your postoperative regimen?
That's a great point. I think your last complication dictates how you currently practice, but I've had a lot of great luck with SLT. I typically start with 1.2 millijoules and a normal eye, and then I will titrate my power, looking for those champagne bubbles on every other shot. But with a pigmentary patient, I will probably start below one and kind of just titrate up or down, but usually would consider having the energy as I start.
That makes a lot of sense. And do you provide postoperative drops to these patients? How long do they do them? What has been your experience with that?
That's a great question. I do pre-treat and post-treat or pre-treat these patients with an alpha agonist, and then based on the evidence from the light trial, I think a non-steroidal anti-inflammatory is superior. I think a steroid is also something that could be considered, and I do think patients are more comfortable, and there's some evidence that SLT is more efficacious with those medications on board.
And in these patients, when you perform SLT and you maybe don't get the response that you thought you would, do you tend to repeat the SLT or would you consider other treatment options?
That's a great question. I believe the definition of insanity is trying something over and over again, hoping for a different result. So, if somebody had no effect to SLT, I probably wouldn't consider repeating it unless for some reason I thought that there was maybe an undertreated SLT or done by somebody else. I think medications are a next place that I would start. I definitely would typically start with SLT, but if there was a problem, I would try meds. I like a prostaglandin analog first line, and then would consider maybe a beta blocker, trying to keep this regimen somewhat simple. There's a lot of data in our field that the more complicated the drop regimen, the less compliant with the patient. And then would consider a filtering surgery later on. Personally, in these patients that are myopic, we have to be concerned about some risks of filtering. But I also love a filtering procedure like a trabeculectomy, a tube, or even a Zen gel stent is great in my hands for these patients.
I haven't heard of the newer mixed procedures being included in the armamentarium of these patients. I mean, I've seen it in my experience in a lot of primary open-angle glaucoma patients. I know in pigmentary glaucoma, tend to do a lot more angle-based surgeries. Could you talk us a little bit more about the role of minimally invasive glaucoma surgery in these patients?
This is a little bit of a personal philosophy. I agree with you. There's some questions about, if the drain is sick, should you just excise it? I think that's a very reasonable thought process. I personally believe that we were born with these tissues and we should try to get them to work better, which is why I like SLT and other procedures such as the newer field of MIGS and filtering surgeries to help. I agree with you. It's a little bit of a newer area there, but I definitely think there's help, and specifically with the Zen, because depending on your Zen technique, you might be able to minimize hypotony with a smaller lumens device.
That sounds great. I think that the 24-hour IOP control is so important for these patients. Like our patient in this case, for example, has the typical I'm going on a run or I'm working out and then my eye is hurting as the pigment's releasing. So that the controls, especially in those pressure spikes, really damages these patients. So the 24-hour control, as you said, is so important either through medications, SLT, or as you said, filtration surgery. Have you had any experience with performing trabeculectomy on these patients? And do you modify your technique given the myopia and the risks involved?
I have had to do a trabeculectomy in a patient like this when somebody shows up with severely advanced vision loss and they don't have much room to wiggle with. There's nothing like a trab. So that's a little plug to everybody doing their glaucoma fellowship. Make sure you understand how to perform a trab. But it is a little bit of a harrowing experience because there's nothing that will ruin your day like hypotony. As we know, hypotony is much more challenging to treat. And I think the risk of hypotony has to do with their myopia, but it could be something to experience. But you definitely want to do it when you're in town, not before you're going out of town, so your partners are happy with you.
Yeah, those are excellent pearls. Having been, a resident who completed the glaucoma rotation last year, I can definitely say that it comes with its own issues. Depending on how and who who's performed for. So um, that's definitely something to keep in mind. And so going back to our 40-year-old gentleman, how would you counsel this patient and what would you initiate as treatment for both the right and the left eye? As you said, you were concerned about glaucoma in the left eye and then maybe some early signs in the right
Yeah, I think for the left eye, it's a little bit of a easy call there. I definitely would consider treating the left eye. I remind patients, I'm not here to tell them what to do. I'm here to collaborate them on a treatment plan. So I would definitely talk about medications and SLT as first line, and make a treatment plan for that left eye. The right eye, I would call suspicious without seeing visual field findings. I would definitely counsel them on the fact that that eye could change. It could also be stable. Then I would also indicate the need for a lifelong follow up and also recommend first degree family members are evaluated and checked for glaucoma. There could be a hereditary component to this.
That's awesome. I think the hereditary component that you touched on is so important. I don't think a lot of us think about that, but that's important to keep in mind as well. Um, and what would be your follow up? You mentioned the importance of lifelong follow up. Like, how closely would you follow this particular patient, and what additional testing would you pursue?
I usually will titrate follow up to how the patient's doing. As I joke with my patients, the better you do, the less you see me. but pigmentary glaucoma in particular can be stable for quite some time and then present with very high pressures and very difficult to control. So I do think regular follow up, at least 3 to 4 times a year, is extremely reasonable in these patients.
And circling back to the IOP spikes that you were talking about, I know in these patients, especially as you mentioned, after certain procedures, or just naturally, these people can have IOPs in the 50s, 60s, uh, and come in the acute setting. Uh, if you cannot reduce the intraocular pressure with drops and Diamox or acetazolamide for all of our listeners, do you think about any other interventions to reduce the intraocular pressure? I know some people advocate for an anterior chamber paracentesis as a kind of a temporizing measure, and then we'll see how the pressure does. There's maybe some thought that it kind of shocks the trabecular meshwork and maybe reduces the IOP, especially in these labile patients. What are your thoughts on that?
Yeah, that's a great question. I'm not a huge fan of anterior chamber paracenteses for elevated intraocular pressure for a couple of reasons. One, in a healthy eye, you're creating fluid at aqueous humor at 100 microliters per minute, so it's just going to come back. I think, or excuse me, the a microliter per minute. There's 100 microliters, I think, in the anterior chamber. But the concern with a paracentesis is that you're not going to it's just going to come back in. But if you have put the patient on an aqueous suppressant, such as acetazolamide, such as a timolol, and then you've and reduced the production of the fluid, then it can be helpful. But you're usually buying yourself enough time to call your attending before you make a more definitive plan. So temporizing is fine, but yes, not a definitive treatment.
Yeah, I think that's such an important point, especially in these patients, and more importantly, in angle closure patients. It carries a lot of morbidity, so it's very important to selectively perform it in patients. And I would say most patients in our institution would not receive AC taps unless absolutely necessary. So
And
that's
to
great.
piggyback on that, if the view is poor, you definitely do not want to do an AC tap. You could damage the lens or other structures, nick the iris, and then cause bleeding and make your situation a lot worse.
Yes, yes, that's so true. It's been interesting to see these patients in clinic because I think patients with pigment dispersion syndrome and pseudoexfoliation have both so much, I guess, corneal reserve in my limited experience, because the pressures can be in the 50s and 60s, and because of I think how much the eye is used to it, there isn't a ton of corneal edema or other findings that may be more associated with an acute rise in IOP that the eye is not used to. So I've found that really interesting in these patients, and have been very surprised when I was checking the pressure. I said, "Oh, it says 50," like, but you're not in pain. You don't have a red eye. So that's been really interesting to see.
Yeah, no, I agree with that. A chronic, slow elevation in pressure is asymptomatic. An acute change in pressure is extremely painful, and that's why our angle closure patients are miserable. But somebody can walk into the clinic with a pressure of 50 and be completely shocked that they have a problem.
Exactly, exactly. Great points. So let's summarize what we've learned from Dr. Okafor. Pigment dispersion syndrome is a constellation of examination findings characterized by the release of iris pigment in the anterior segment of the eye. The zonular fibers are thought to rub the posterior iris pigment epithelium in these patients who may be predisposed because they have myopia and this reverse pupillary block configuration. The hallmark of midperipheral iris TIDs occur because of the zonular iris rub, and pigment can deposit on the corneal endothelium, which is the Krukenberg spindle, like we mentioned, the equatorial region of the lens, it's called a Shea stripe or a Zentmeyer ring, and on the zonular fibers as well. We talked about a Sampolisi line that can be seen as an extra line anterior to Schwalbe's line on gonioscopy, which is a finding that can also be seen in pseudoexfoliation. So none of these findings are pathognomonic, though the midperipheral TIDs maybe carry the highest sensitivity. The classic patient is a young myopic male who has intermittent pressure spikes with dilation or exercise, with IOPs exceeding up to the 50s or more in untreated eyes. About 15% of these patients will go on to develop glaucoma, and the treatment is focused on the underlying ocular hypertension and or glaucoma. Larger studies have failed to show the benefit of LPIs, but SLT or selective laser trabeculoplasty can be a very effective first line treatment option, though its effects may be short lived. And starting with lower laser energy is recommended, as paradoxical elevations of IOP, especially in eyes with heavy pigmentation, can occur, as we learned from Dr. Okafor's case. Any additional things you would like to add?
No, good luck with studying. Ophthalmology is the best field in the world, and I'm happy to hear that there are others that feel the same way.
Yes, we are so lucky to be in this field. And Dr. Okafor, before we end each episode, I ask all of my guests one question. And so the question for you is, if you could go back in time and give your younger self one piece of advice, what would it be?
Mm. I would tell younger self to never be worried or frugal when it comes to investing in yourself. You will be surprised at what you can achieve, and you shoot for the stars.
Oh, I love that. I feel so inspired already. So thank you so much for that thoughtful answer. And Dr. Okafor, thank you for joining us on this episode of the Pupil Pod.
Hey, thanks for having me.
And thank you to our listeners. See you next time on the Pupil Pod.